Hello friends. Now today we will discuss about the important concept of renal system. If you are able to understand this concept, then you are able to clearly understand the renal system very clearly and efficiently. Okay. So what is today we are going to discuss is counter current mechanism. This counter current mechanism is required for understanding the both two things is required. One is how urine is formed and why urine what you excrete out is hypertonic in nature, or what are the factors that determine the urine will be hypertonic or hypotonic. Okay, normally you know that I'll overview it. Okay, suppose blood comes, you know that 22% of the cardiac output reaches to the kidney. In kidney, it enters into through the afferent, exits through the efferent. In there will be the glomerular filtration rate (GFR) will occur, and GFR is around 125 ml per minute. You know this clearly that GFR is 125 ml, around 120 to 125 ml per minute, but urine formation is only 1 ml per minute. Means that your 124 ml of water, that is GFR, through GFR that has been come, is reabsorbed from the renal tubules. Okay, so water absorption actually occur in the two phases, two mechanisms is there in the renal tubules. One is the facultative and another is obligatory. Obligatory means the water should absorb and it will absorb, it doesn't require anything. The gradient, the normal diffusion mechanism, it will goes to maintain the isotonic situation. Okay, but there is another obligatory, that is the certain portion of our renal tubules are impermeable to water. So when you talk about the GFR is into this renal corpuscle, there's glomerulus and Bowman capsule. In Bowman capsule, the GFR is 120 ml per minute, or say 180 liter per day, which is and if you compare urine, that is 1 ml per minute, and which is also necessary that clinically you should understand that your patient should form 1 ml per minute of urine or 1.5 liter of urine per day. Okay, to have a normal kidney function, normal urine output, that you have to understand. So you have 125 ml of GFR has been come, then it comes to the PCT, then this is the descending loop of Henle, then loop of Henle, ascending loop of Henle, thick ascending loop of Henle, distal convoluted tubule, collecting tubes and collecting ducts. That is the part of your renal tubules. You know that already. Okay. Now the 125 ml of GFR has come. It will goes into the PCT. In PCT, absorption will occur. After absorption, there will be maximum of water will be absorbed, and that is isotonic. So plasma osmolality is 300 milliosmol per liter. You know that 300 average 295 to 300, we approximate is 300 milliosmol per liter. So you are having this osmolarity of 300, it is going down, water is absorbed, solute is also absorbed. You know that in PCT lot of solutes, all this glucose, amino acid, sodium, potassium, other factors, all are get absorbed in the PCT. We'll discuss detail in next lecture also. Okay. Then it comes down. When it comes down, the water get absorbed. This is the obligatory water reabsorption. When it comes down to the descending loop of Henle, there is also this part is impermeable to sodium but permeable to water. So water get absorbed from this descending loop of Henle. When loop of Henle, but when it goes to the ascending loop of Henle, this is impermeable to water. There is only, if you remember or if we will discuss, that there is sodium potassium 2 chloride transporter that will transport the sodium potassium and 2 chloride from the thick ascending loop of Henle into the interstitium. Okay, into the cell, and then moving to the interstitium. That is important. So it is impermeable to water. Even distal convoluted tubule, collecting ducts, these are also impermeable to water. Okay. Now another thing is the term is facultative. Facultative is in the presence of ADH. You know that ADH secreted by posterior pituitary, and ADH is antidiuretic hormone that requires for the water absorption. What they do, that will create when ADH is secreted, reach there, then there are the receptor, they act on it and form the water aquaporin. That aquaporin, it creates a pores over there that is the water channel through which water get absorbed. Here also there is no force, only it's depend upon the medullary concentration that will try to maintain the water, the osmolarity between the water and the medullary concentration osmolarity with the urine concentration of osmolarity. One thing important is that you have 3 millimosmol of plasma, 3 millimosmol of GFR. In proximal convoluted tubule, it is remains the 3 millimosmol. Okay, but when it goes down, thick ascending loop of Henle, then also it remains 300. So when it goes up in loop of Henle, when it goes to the ascending loop of Henle, then what happens? This ascending loop, there is sodium potassium 2 chloride. This is sodium potassium 2 chloride. This 2 chloride pump will pump out this solids from the thick ascending loop of Henle into the cell and finally into the interstitium. So now the osmolarity of this part becomes low, hypotonic. This was isotonic. I'll talk about here because water has been absorbed but sodium is not, then there will be hypertonic. How it will come? This will explain by this counter current exchanger and counter current multiplier and counter current exchanger that we will discuss. Okay, so what we are going to discuss over here. So this sodium potassium 2 chloride will pump out the solid and let it into the cell and then finally into the interstitium. Okay, so this pump has one important special peculiarity that it maintains 200 milliosmol gap. Suppose here is 300 has been gone, then it will take out 300 and remain 100 and it will give slow interstitial fluid. This is the main properties of this sodium potassium 2 chloride chain. So how this counter current multiplier will work? See, you have 300 milliosmol, but when you pass the urine, in every place there is sodium and chloride has been absorbed from your solid component is absorbed from the urine. So your urine is getting diluted and diluted, hypotonic and hypotonic. That you have to understand. Okay, so when you do nothing, then this will there will be what 200 finally come to the 100 milliosmol will out from the ascending loop of Henle. So that is in comparison to 300 ml, it is very low. And even then goes to the distal convoluted tubule and into the collecting ducts. There also sodium and chloride will be absorbed. So more solid will be taken out. More there will be hypotonic urine will be formed. So if you think about the hypotonic urine, so there will be GFR will filtrated, it goes to the renal tubules, then the thick ascending loop of Henle, that will solid will get absorbed, and distal convoluted collecting duct solid will absorb, and your plus urine concentration, if you measure your urine concentration at that point, then it will be 50 milliosmol per liter, which is very hypotonic in comparison to the plasma. This occur in condition when ADH is not secreted. If ADH is not there, if ADH is not has been released or due to any problem, now your urine will form hypotonic in nature. This is mechanism of formation of hypotonic urine. Okay, urine is formed by 3 mechanisms, that is Goldman filtration, then tubular reabsorption and tubular secretion. These three play the key role. Okay, now when we come to that point that okay, hypotonic urine has formed. Now there is another mechanism which is hypotonic urine is usually not formed all the time. Okay, most of the time we will find hypertonic urine, that is our urine plus milliosmol is more than, it is around 1200. How it get formed, that is the explanation of this counter current mechanism. Okay, so when you come to the counter current mechanism, you have understood, we have understood over here that in proximal convoluted tubule the milliosmol is 300 milliosmol, then it goes down in distal convoluted tubule, water get absorbed but sodium is not absorbing. Okay, when it goes to thick ascending loop of Henle, there this sodium potassium 2 chloride is get into the interstitial fluid. So you have sodium potassium get into the interstitial fluid and there is maintained up to 100 gap. Now your concentration of the solute in the cell and finally into interstitium become 400. Since the concentration of here become 400 and this part is only permeable to water but not to the sodium, this water will come out. Okay, and here also the osmolarity will goes to the 400. This is, I have already told you, this is normal, if you understand the water diffusion, water will always try to make it equilibrium. It will always try to make the equilibrium by maintaining the osmolarity. So since here 400 become, now water is more here, so water will be make equilibrium and make the osmolarity over is 400. Now your osmolarity here becomes 400. Now this 400 is going through the renal tubule. This is in the interstitial fluid. It is again going. When it goes over here, this pump is again there. This pump will again pull out and maintain the 200 gap. This will be 300. Now your osmolarity is 500. This is interstitial is 500. So this tube will also try to make 500 and it becomes 500. In 4 to 5, 6 or 7 steps, your concentration in the same mechanism, that interstitial fluid will be here will be 1200, and the same to maintain the osmolarity of interstitial fluid 1200, the thin descending loop of Henle will also maintain 1200 osmolarity, and this is going through your renal tubules. Okay, now this concentration has been achieved. More than this is usually not achieved. So now osmolarity is 1200 in your renal tubule in thick descending loop of Henle. Now what we'll do, this thick descending loop of Henle will co-equilibrate with the one of, then this is the counter current multiplier. So by multiplying, it will through these renal tubules, it will reach the osmolarity of 1200. That is important. You have understood that how counter current multiplier has occurred, and your osmolarity in thick descending loop of Henle has reached to 1200. Now important another concept is about counter current exchanger. Since now there is 1200 osmolarity, now this will pick up by there is the peritubular capillaries very close proximity to this loop of Henle. Okay, so this will, the 1200 will be comes into this peritubular capillaries. Normally in our blood, everywhere in the body, the osmolarity is only 300 milliosmol. Only in the, if you understood this tubules, there is cortex and the medulla. In the medulla of the kidney, where the peritubular capillary is present, only that portion of the peritubular capillaries can have osmolarity up to 1200. That you have to understand. So everywhere there is 300 milliosmol, but when it comes to this peritubular capillaries, there, which is in the medulla of the kidney, that will take up this 1200 osmolarity into it. The solute will enter into it, water will diffuse out, makes the equilibrium and reaches the 1200 when it goes down. Other part of the peritubular cavities, it will be 300 only. When it comes here in the thick descending loop, descending loop of Henle, then it will pick up this concentrated by taking solute, releasing the water, and it will carry out, and when it goes to upper limit of this loop of Henle, when it ascend out, it again will give the solute outside and take water inside. So what will form now? Now the condition will again, this is just a vehicle to transport that osmolarity. Now the osmolarity has been present here will be 1200. So now the interstitial fluid of your medulla has osmolarity of 1200. Now what happens if your urine, if this osmolarity and there is this collecting tubule, distal tubule, they are impermeable to water if there is no ADH. So what has been passed, this 100 milliosmol, if in 50 milliosmol, that will pass as a urine, hypotonic urine. But if ADH comes, then it will act and the distal condylar tubule and collecting ducts and collecting tubule creates the aquaporine, that is water channel, and through water channel, now what happens? Again there is high concentration of solute. This is medullary concentration is very high. So water content, if remain here, will be get absorbed and they will make the equilibrium, because now there is water channel is present and water will make its equilibrium. When you make it equilibrium, now the water will be get reabsorbed, okay, from distal also, from the collecting duct also, and from there, and now your urine concentration will become 1200. That is now the osmolarity of the urine that is passing is how much? 1200. So what you will going to be is now osmolarity of 1200 milliosmol. So if you are understanding this, then it will be very easy to now deal with the renal system, its detail of every PCT, distal convoluted thick ascending loop of the leaf, what is get absorbed, what is get reabsorbed, what has been excreted, how the diuretics will work, and everything will be explained easily. Okay, so this is a very important concept. Actually, it takes a lot of time to understand this concept. Even I'm a gold medalist, say that 80% honors in physiology. I have been honors in physiology, anatomy, pathology, but this took me a lot of time to understand, and it even was difficult for my professor to make me understand. It takes a lot of discussion, a lot of understanding, and a lot of reading to make this mechanism understood. And if you know that now, you understood why you have a diluted urine if there is no ADH, why you know that why your urine get concentration and it is to 12 millimosmol, and about the water reabsorption also you have know the concept of water reabsorption. This concept now will be easily understand all other further about this urinary system physiology. Thank you.